Well, welcome everyone to the Washington State Telehealth Collaborative. This is John Scott. I'm the Medical Director for Telehealth at the University of Washington and chair of the collaborative. And I think we're going to get started with roll call here. And we are very pleased to be hosted by Gonzaga University. And so we just wanted to, first of all, thank them for hosting us today. For those of you who are not here in person, they have a brand new building called the Hemington Center that's, we're all just remarking how nice it is. And we're overlooking great athletics facilities and their famous football place, the Kennel Club and everything. So it's a great atmosphere here. What I'd like to do is just do introductions in the room. Maybe we can start with you, Jeff.
Yeah, I'm Dr. Jeff Jones. I'm a family physician up in Newport, Washington, which is about an hour north of here. I'm also the Assistant Clinical Dean for Eastern and Central Washington for the University of Washington School of Medicine, based here at the UW-GU Regional Health Partnership. So our building is just over there, and it is not nearly as nice.
Not yet.
Joe Schmidt from the 9th Legislative District. Welcome to Eastern Washington.
Randy Becker, State Senator, 2nd Legislative District, Mount Rainier.
I'm Marcus Riccelli, 3rd Legislative District, which we're sitting in right now, and the school that I went to in that nice field was a mud pit when I played intramural, so extremely jealous looking at it.
John Bowes with Labor Industry.
Hi, my name is Scott Bloom. I actually manage the state's Traumatic Brain Injury Council. I work for PSHS.
Okay. Scott Broom.
Bloom.
Be like a
Bloom.
Okay, great. Right.
Hey, good morning. Lisa Rocha with Providence.
Okay. Now we got Lisa from Providence. And on the phone then, I'm just kind of looking at the roster here. Let's start with Brody DeChinko. Brody, I know you had a meeting you had to run to, but you're on the phone?
Yes, can you hear me?
Yeah, and can you hear us okay?
Yeah, perfectly. Brody DeChinko calling in from Seattle with Cambia Health Solutions / Regents Blue Shield.
Great, thanks Brody. Next, Dr. Joshua Frank.
Hi, good morning. I'm Josh Frank from American College of Emergency Physicians. I'm the ED Medical Director in Wenatchee, Washington, Central Washington Hospital.
Great, thanks Josh. So just for those of you who have been coming for a while, Dr. Sue Stern, who's the ER Director at Harborview and Chief of Emergency Department of Medicine, has had to roll off, and so Dr. Frank and Dr. Frank's colleague, Dr. Kie, will be representing that position. See, next if we can talk to Karatal.
Hi, this is Karatal. I'm coming to you from the University of Washington Department of Psychiatry. Wish I could have come out to Spokane this week because I actually am a proud graduate of Meade High School out in Spokane, Washington, so I could have visited both.
Me too. Great. And Kara, is Dr. Unitzer going to be joining you in a little bit?
He's not going to be joining me, but I know that it's on the calendar. I've been in touch with his assistant, and so he will be joining shortly, I would imagine.
Great. Joelle Fathi. Joelle, do you just want to introduce yourself real quick?
Oh, sorry, I had myself double muted. Can you hear me now?
Yeah, go ahead.
Okay, thank you. Representing Washington State Nurses Association and the University of Washington School of Nursing. I'm a nurse practitioner with a background in telehealth.
Great, thanks, Joelle. And Kathleen Dahlman from Swedish.
Good morning. Kathleen Damon. I'm a clinical program manager, nurse from Swedish, calling from Seattle.
Great, thanks. Sarah Orth from Seattle Children's.
Hi, this is Sarah. I'm the telehealth program manager here at Seattle Children's.
Great. So I don't recognize any of the other phone numbers, so I'm just really briefly just going to do a quick roll call. Chris Cable, are you on the phone or on video? I didn't hear whether he was going to join. And Senator Cleveland, were you able to join? Okay. Francis Goff. Sheila Green Shook. Cheryl Huchala from Primera. Ricardo Jimenez. Dr. Kie, I don't know if Josh, if she also was going to join. If not, Scott Kennedy said he could not attend. And then I'm wondering if there's anyone from Multicare on the line. For those of you who are not aware, Emily Yu left her position at Multicare and had a couple people listed as replacements, including Chris Kitts. But I'm wondering if there's any from Multicare who can please chime in. Anyone from Multicare? Okay. Next, Denny Lorden sends his regrets. Really sad that he's not here since he lives here in Spokane, but he is at a family wedding in Boston. Adam Romney, are you on the line?
Yeah, Adam's here.
Great, thanks, Adam. Let's see here. And Lori Wakashigi, I think, had sent me a out of office response. But Lori, are you on the line? Okay, great. Anyone else who's a formal member of the collaborative that I may have missed?
Hi, this is Chad Gablein from Virginia Mason.
Thank you, Chad. I apologize. Yeah, my chicken scratch when I'm taking notes on what I couldn't see your name. So thanks, Chad. All right. Anyone else? Great. So for those of you who are members of the public,
Chris Cable.
Sorry.
Just getting my computer figured out. Joining a moment late. Sorry.
Great, Chris. Glad you could join.
This is Stafford Strong, also calling from the Senate Republican Caucus.
Okay, great. Thanks, Stafford. Glad the technology worked out for you. So for those of you who are members of the public, we will have a period of time at the end of the call for comments and questions. What I wanted to do next is to share my screen, and we'll go through the agenda. And the first thing is to review our last meeting's minutes. Those of you who got those on the email attachment, we can go through that. And what I will do is pull those up as well. So just to highlight a couple of things for folks who may have not have joined last time, we did talk about the OCHIN, which is a health IT consulting nonprofit in Portland. It's a great resource, especially on the kind of connectivity side of things. They work with the California Telehealth Resource Center. So we will move on. And today to talk about parity, we had quite a bit of lively discussion on that, and we'll renewing that discussion. And here we learned about the All Claims database from Thea Mounts and the Office of Financial Management. And if anyone wants her slides, please email me and I can forward those to you. We were not able to get to the training certificate requirement. We will talk about that today. And that's about it. So maybe if we can entertain a motion to approve the minutes.
So moved.
Okay, thank you, Representative Schmick, and Senator Becker seconded. Any discussion or edits that people would like to make?
Discussion?
Yep.
I just want to say, not because I did not attend the last meeting, I was gone. These minutes were probably the best minutes I've seen in forever, and could actually know what happened at the meeting, and I made a bunch of notes and I really appreciate it, so thank you.
Yeah, I just want to acknowledge in my office that was Leah Rosengaus who was taking notes, and Leah is on the line today and taking notes. So Leah, thanks again for doing that. Any edits though that need to be made? If not, can I see a vote to approve that here in the room? All four? Anyone against? And anyone on the line that does not want to approve them, please speak up now. Otherwise, we will say that they were unanimously approved. Okay, great. So I'm going to next go to our next agenda item, and that is that we wanted to take a little bit of time to talk about the training requirement. So that was actually in Senate Bill 6399, and so Denny unfortunately couldn't join us today, but he had prepared some comments from folks, and I'll let you review them. And but I wanted to kind of go to the end that there's a comment from the American Telemedicine Association that this is unusual to have a training requirement. There's no other state that has that, and that there's just a concern about providing an additional barrier, and just a little bit more. So if you are on the line, if you could just please mute your audio for now. I think we're getting a little feedback. Great, thanks. However, there were some very good comments or suggestions about, like for example, what's going on in New Jersey, where they require any kind of diagnosis, treatment, consultation. If you could please mute yourself. If you're not speaking, that's great. That's why we get the feedback. Thanks. So I think Sarah Orth actually had some really good suggestions too, that maybe there could be an online curriculum so that people can really get educated about this. But I think this is a summary of reactions to this from mostly provider groups, mostly physicians and hospitals. So please take it as such, and just a summary of those discussions that Denny had. I don't know, Senator Becker, if you wanted to say anything more.
Oh, I would really like to, because I don't think my intent in writing the legislation was to make somebody go physically, but when we're looking at training, most of the medical schools are not offering telemedicine training in their medical curriculum at this point in time. But my thought was to have MDs, DOs, specialists, that sort of person, maybe do it through Project Echo and do like you do with the training, that they could just go through and learn what are the what are the basics of telemedicine. Those that are members of large groups have information more readily available to them than those practicing out in the smaller communities or still individual practices. So I thought that might be a way to enable them. In no way or shape or form do I want to put any barriers in front of them, but my concern with training is more at that lower level provider, the different, not the MD and the DO and the specialist, but the providers of, counselors, et cetera, that are not in that same category. So I do think that there should be a what is telemedicine, what are your responsibilities in that, what makes a visit, so that they're not doing something inappropriately without having any resources to find out what's the correct way to do it. As far as making them certified, I think that my thought process is not for the medical doctor community, but for those different levels, is giving them some kind of a responsibility to complete that training before they could actually provide those services, so that they know what they're doing.
Yeah.
So that's pretty much it.
Yeah, I'll share a little bit of what we do at the University of Washington. Is that you have to be privileged for telehealth, just like same kind of process as you would if you were doing any kind of invasive procedure like endoscopy or even central lines. And we have a 1-hour online training It's called an LMS. And Kathleen, my understanding is that Swedish Providence has a very similar system. Is that correct, Kathleen?
Yeah, that is correct. We have online courses that they need to take, and then we actually do a visual, watch them do a return. We demonstrate, then have them sign off on a return demonstration so that they are observed being able to go through the process. We have all the legal pieces, all the information that Senator Becker is referencing.
Yeah. So we have things that, like, how do you consent? How do you introduce yourself even on a telemedicine visit? Then just for going around, I wanted to check in with Sarah Orth and Chad Gavilan. What do you guys do for training at your institutions?
So it's very similar to what Kathleen just described. And so we have video vignettes, and then we have assessments and kind of some basic quizzes and so forth for our docs to make sure that they're using it appropriately and that they know the legal ramifications every time they do an encounter. I think I appreciate your comments about the privileging piece. I guess what I start to wonder, however, is that with a smaller organization such as ours, where we sometimes do physician group sharing from other organizations, I wonder what your thoughts are on that, because that can get pretty complicated when you are working with large, augmentative physician groups and trying to ensure that they're privileged. I don't think you were suggesting that, but I kind of want to hear what everybody's thoughts are.
Yeah. So Chad, maybe we can just put a pause on that, because it's a great question. I'm going to come back to that. I just first want to hear what Sarah is doing at Children's.
Hi, everyone. This is Sarah. We also have a privileging process that includes a simulation. So we go through the technology and the training with our providers in the environment that they'll be using it, using the technology and networks that they'll be using. We also provide go live support. So their first 1 to 3 visits, or however many they need, will be there in person next to them to help them work through everything. We also go through the clinical standards and documentation with them. So from the American Academy of Pediatrics, what do they say about telehealth? And then for that clinical service in particular, and go through also the administrative and operational things that they need to do differently for telehealth, like related to billing and consent documentation and liability and those things. So it's pretty rigorous. We tailor it to each provider based on the service that they offer and the modality that they use.
Great. And Sarah, could you just elaborate a little bit more on what you had said in that document that was circulated about a way of maybe providing generalized training for at really the target group that Senator Becker was talking about? Do you expand on that idea?
Which one in particular?
Well, you were just saying, maybe there should be a generalized training that the collaborative actually comes up with.
Oh, yeah. If there was something pretty general, what is telehealth, what is telemedicine, what are the modalities, where do you go as a provider if you want to do a service like this, to figure out what the clinical standards should be? Because these days, the American Telemedicine Association has a lot of standards put out, but then based on your specialty groups are coming out with standards, and then they're different, obviously, for pediatric versus adult. So as a provider, how do you start to unpack all of that? If the collaborative could put together something like an online module or curriculum that we could use to point people to as a starting point, that would be really helpful. And or even to filtrate into schools, from undergrad all the way up through residency, training, and deployment. What does that look like? In the state of Maryland, we tried to get a requirement passed into law that required a certain number of hours for residency related to health information technology, which would include telehealth or telemedicine. We couldn't get that past the medical schools didn't want to have that legislatively mandated. We also looked at having providers have a certain number of their continuing education requirements or be related to health information technology, so that they would at least be getting some sort of refresher or keeping up, because this is a very fluid legislative arena. So if the collaborative could be a resource for providers in that kind of endeavor, it would be great to have a single source of truth that was put together by all the people that are on the collaborative.
Yeah, great. And just so for folks who may not know, one of the first things this collaborative did is we created a frequently asked questions document that was for both patients and for providers, and it has links to like the American Telemedicine Association best practices. But maybe if we can, it sounds like what you're saying, Sarah, is maybe if we pool our collective wisdom and put together an online training. I mean, having done this for UW, it's basically taking PowerPoint slides and somehow putting them online. It was not that hard, but I just want to see if there would be interest as a collective group to help put more of a general document together.
Thank you, Joel. I think that's a great idea. And I wanted to circle back around with Senator Becker's comments about who should be brought to the table in terms of training. And I really think that we have an opportunity in the state to, number one, lead practice and standards as it relates to telehealth. And really anybody who's engaged in a telehealth encounter, including nurses, non-licensed independent practitioners, really should be getting some baseline training so that they understand what that security, privacy, confidentiality, conduct, integrity of visits really looks like. And so I think we just have a really great opportunity. We're still sort of on this cutting edge of telehealth. And there are so many other entities that are out there engaged in telehealth. I think if we created a resource that anyone could access, I think, again, we would set a higher bar for standards across the state and certainly in the U.S.
Thanks, Joelle. That's really helpful. I wonder if we can come back to Chad's question. Chad, would you mind just restating your question?
Yeah, so I just kind of wanted to introduce the concept that sometimes like we tap into augmentative provider groups to help supplement our own telehealth team. And so in those cases, certainly we want to make sure that, they've done some education with their docs. I think where it gets a little sticky is to assure that there's uniform education. And so I kind of was just putting that out there to, first off, introduce the concept of these augmentative provider groups. And then, does anybody have any strong opinions, or have they had experiences in this? We can certainly parking lot this. I think for a smaller organization, it's probably a little bit more of an issue for us. And we certainly like to follow the ATA and AHA guidelines for all of our programs. But it does present some interesting challenges when we're talking about legislature.
Yeah, so Chad, you're thinking like you and I, we use Karina. Is that kind of what you're thinking of?
That's absolutely correct.
Okay, so yeah, so both Virginia Mason and UW, we have partnered with a telemedicine company called Karina, now American Well, and I know they have their own training. It's called Karina University, so that's probably one of the gold standards for training. But Chad's point is well taken. How do we assure these third-party vendors are up to snuff as well?
Can I ask a question that maybe I'm missing something or just naive to this, but also as far as kind of uniform standards, I have no clinical background, but in my day job, we're bringing a lot of behavioral health providers, and it seems like what you would be training folks on.
Yeah.
There's another aspect too. I mean, there's just the technology. Like we use Chiron, which is a different delivery method that integrates with Athena that we use. But I guess I think there's like this small circle that's the basic piece, but then it very quickly would be hard to uniform certain things like behavioral health providers versus, they're not hands-on, so there's a big difference there, right?
Right. Maybe what I would propose is that if I can loop back with Kathleen and Sarah, Chad, and some of the other providers of multi-care and legacy, and see if we can kind of put together a general document, and maybe at the next collaborative or the one after that, we have a sample PowerPoint that people can look at, and it'd be very general.
Yeah,
and that. What do
John,
you think about that, Kathleen?
Yeah, I was going to support Sarah's comments earlier. You know, there's a general basic information that talks about the differences between telemedicine, telehealth, what kind of modalities are available it's the basic information. And Joelle had mentioned having not only the license, but also like the MAs. Everybody needs to have that basic understanding of the legalities behind it, the ethics, et cetera, et cetera. So I think we were able to put together a document that shared that information. It's sort of as a base. Each professional route is going to be different. Behavioral health, I mean, who needs hands-on, who doesn't need hands-on? Are we doing a full physical exam or listening to heart sounds, et cetera? Those are going to be a jaunt off, and those will be specific to that specialty. Whereas everybody else should have that basic knowledge. You know, we don't want someone just popping in and sitting in on a call without getting information about it. We want the doc to show, or the provider to show their identification and introduce themselves and make sure that there's consent. So there's a lot of those basic pieces that I think would be helpful for people to understand the base piece, as Sarah said, and then from there you can kind of go out and look at all the different pieces where you have the specialties, et cetera. And I'd be happy to participate in that as well. I think that's a great idea, John.
Okay, thanks, Kathleen. I want to just do a reality check here, and maybe Jeff, if I can put you on the spot, since you work in a small practice in Newport. I mean, if you want to do telemedicine, how much of a burden would this be for you? Is it overly?
I think there's several questions there. So the way I'm also hearing it is that if we had a patient in Newport who wanted to visit with a neurologist in Spokane or Seattle via telehealth, we would, having the subspecialist definitely certified, trained, privileged, that's great. But then what I understand, this would also mandate that our MAs that were even rooming the patient, and that Newport Hospital would have an obligation to make sure that those MAs were trained and completed some training in telehealth to appropriately room the patient and set up. That would be a little bit of a barrier because we have a hard time getting MAs that can room people, period, let alone do any complex additional tasks. Second, for me, me personally as a physician, if I was going to offer any service, I would make sure I was competent at that and get whatever training I needed. I don't think you have to mandate telehealth any more than you would mandate a data waiver for Suboxone. As a physician, we have to be competent in the services provided, period. I also, and then putting on my hat as a clinical dean, I can tell you also, like, suggesting or even mandating that telehealth training is included in undergraduate medical curriculum would meet with a lot of pushback. I think you'd have to be able to explain what else you're going to give up. And then again, you got to keep in mind, physician training, we are taught to treat and evaluate the patient using whatever tools are, whether it's a pinprick or your own hands, a stethoscope, whatever. And we don't tend to offer specific training and certification in stethoscopes or reflex hammers or any tool that we use. Does that make sense?
Great, really super helpful. Senator Becker, do you want to respond to that?
Well, when you were talking about medical assistants, of course, I worked with them as well, but, they all, if they're certified, they go through 18 months of training, and we might be able to talk to some of their, those programs out there and see if they would consider teaching it within their program.
It'd be a big plus for their graduates, but again, it's not like we have graduates competing for jobs in Newport or anything.
Josh, you had typed in a little chat. Do you want to elaborate a little bit more on what you had chatted in?
Just listening to the different points of view, maybe Senator Becker can comment. It sounds like we're talking about a lot more than maybe her initial intent was. It sounds like she wanted to establish just a fundamental baseline of, you know, the best practices, the basics of training, and just make sure that that was at least taken care of. And
Yes.
also thinking that in an office, you could specify that the provider is the one that has to be trained, because the provider is going to hopefully educate the staff as well. And every office is a little different. And if a nurse is trained initially in school and she comes out, she works for a while and doesn't do telemedicine, then still if she joins a practice and starts working in an office that does that, he or she will need to be retrained a little bit. And so I was thinking we could simplify it, just make it providers should review these best practices. You make the best practices, publish them, and then each individual site can make sure that they at least cover those, and they'll probably do a heck of a lot more like most people are already doing. That was what it sounded like the kind of mission was. And then the legislature can have something to look at, to know what the standard is if they're comparing against other things that they see.
Okay, thank you for that.
I agree. I mean, I think if we get so far down in the weeds with our medical assistants and, you know, and your counselors, et cetera, but I also believe that if they're in I'll use my hometown of Eatonville, and there's one provider, one medical doctor, one physician assistant, and then they're utilizing maybe a medical assistant they've trained with protocols to work within, for example, the AIMS program, that person will need to know what the legality. I mean, you do not want your medical assistant causing a lawsuit because of not knowing the issues and the rules. So I think it's a valid point that at some point in time it'll have to be expanded, but I think we need to start with a baseline.
Okay.
Do you envision someone then monitoring this? How is it going to be done? Who's going to do that?
That's a great question. Someone
it was on here, and that's how.
Yeah, is this the Medical Quality Assurance Commission? Is this part of your annual renewal? And I have no idea.
Because if we're going to have this task, someone's got to be responsible.
Yeah, there needs to be I guess a stick or an enforcer, right?
I don't like that term, but yes.
So it would be a requirement, even through the base piece.
Through the base piece is at least to have undergone, like Providence is already doing.
Yeah.
And like Virginia Mesa is already doing. It's that individual provider out there that's not going to have access to all of what the bigger organizations are.
Well, I can't speak to the enforcement, but I'll just draw from something. So I coach youth sports, right? And now we go online. We have to go through all these trainings. And
on concussion, right?
On concussion, all this stuff. And at the very end, through that system, when you've completed it, it allows you to generate the certificate that you could print, or you know, just something like that.
Or even when they're doing, if it's if you do a medical license, it just says I've completed the course, and you check it off, and you have to attest that those are true facts. So we don't have to make this hard.
Okay.
I see a lot of folks just do it. They just be like, well, I'm not doing telemedicine, so I don't need to worry about that. I might think about making it a requirement for billing. Like if you're going to bill state-funded insurance, you know, whatever, then if you're going to bill them for telehealth, you have to have other.
Do you have certified billers? Certified coders?
Oh,
Did everyone hear that? What Jeff said about rather than making it a requirement for your licensure, but it's a requirement for billing. Reactions to that?
The billing, this is Kathleen. The billing changes on a regular basis, frankly. I mean, you know, it's quite a bit of a challenge. So we work with Lisa Roach. I think Lisa's on the call. And we've been sort of juggling the billing changes as they occur. You know, and also just going back to the professional licensing and licensure underneath all of our advanced practice clinicians and physicians, you know, you have to practice within your scope. And I think when you we don't, I don't know that I would want to say that all of our physicians have, and we keep track of all of the certifications. As soon as the physician signs off or the practitioner signs off that they've done this, we keep it in a file and show, so that if DNV or anybody else wants to know, have we followed training protocols? Have we done what we need to do? Are we following the ATA or any of our state legislature? We have a record of all of those, all of that, the training that we've done with our providers. The billing piece is really challenging. I'm not sure what everybody else feels like it, but it's a bit of a challenge to stay on top of it.
I think maybe to wrap this up, because I know we have a lot to talk about, for an action item for next time is that I will be circling back with Kathleen, Chad, and Sarah, and we'll put together kind of a generalized training PowerPoint for folks to review next time, and then we can talk a little bit more about the structure of it. I really like your idea, Representative Riccelli, is just, that there is some kind of a certificate, or yeah, you can print it out and you can show it. We might need a little technology help for that. I don't have that readily available. But any other comments or questions before we move on to the next agenda item?
Well, it might be the training, and like they have a quiz. Once that quiz is completed, then it would generate that.
Yeah.
And then you have every base covered. And
yeah, I have questions written that are pretty basic, so we can do that.
I saw the recommendation of a CME module already before, and that seems like the logical way to go.
Okay. I know for at the UW to get CME credit, it's an annual thing that I need to apply for. It's about $800, and then if you're a physician, you have to pay around $40 to $45. I don't know if anyone can do it cheaper.
Can it not be done through the malpractice carrier as part of? Because that's free.
The question is whether we can do it through malpractice carriers. I don't know. I can look into that.
That's a great idea.
Not to create the document, but to facilitate the training out to those providers.
Yeah. I know folks can't do this on the phone, but just this is what I can pull this up in my email. This is Sideline Sports Doc.
Got a nice little
youth soccer injury recognition.
That's framed in your office.
Well, not really framed, but
great. I'm sorry. There's Chris. You wanted to say something?
Yeah, just something for us to think about a little bit. So I absolutely appreciate the spirit and intent of making sure that we're providing care by people who understand the right way to do it and to do it in a safe and appropriate way. Part of the thing I'm challenged with is thinking about the telemedicine laws that exist right now. It excludes telephone calls, so I presume what we're talking about may exclude that as well. And then it becomes complex to think about, well, what's fundamentally more risky or unsafe about a video visit versus a phone visit, and do we want to regulate or require training for phone visits as well? And so I have a hard time thinking about strategy behind why one, not the other, and if we're going a little bit too far down the training and regulatory road.
Yeah, I mean, I can think of one major difference, Chris, is say you're beaming into someone's home and in the background you observe a child being abused. You couldn't see that on the phone, right? And we as physicians are all mandatory reporters. That's one major difference, and people need to know that. So I'll just throw that as an example of how that would be different. So. Okay. Any other comments or questions? Okay, great. Thanks everyone for those really helpful comments. If it's okay with Senator Becker, I want to just flip-flop our next agenda because I know Dr. Unitzer needs to run. But I wanted to turn the mic over to Dr. Jürgen Unitzer, who's the chair of psychiatry. And this is by way of introduction to the concept of payment parity. So the idea that was floated in Senate Bill 6399 is that there are 4 or 5 areas that if you are providing the service via telemedicine, then it would basically be billed the same rate as an in-person visit. And I think Dr. Unitzer just really wanted to comment on the importance of that. So Jürgen, do you want to elaborate and take it away?
Yeah, hi, can you hear me okay?
Yeah, loud and clear.
All right, hi, this is Jürgen Unitzer. I'm sorry I'm not with you in person. I'm telemedicining in from Seattle, Washington, here at UW. I chair the Department of Psychiatry here, and I'm going to share a few thoughts based on going on 10 years of experience of really working with mostly primary care clinics throughout our state, and more recently doing a fair amount of telepsychiatry into a whole host of different primary care and in a few cases specialty care settings in the state. And the reason we do this is we have in this state and in a lot of other states a tremendous workforce shortage when it comes to mental health, psychiatry, and psychology in particular. So in our state, for example, we have, in our 39 counties, about half the counties don't have a single psychiatrist or psychologist. So if you're living with a serious mental health or substance use problem, you're not going to see somebody in your county who can help you with that problem. And that makes, a tremendous, a case for us to say, how do we use technology such as telehealth technology and take the providers we do have and distribute them a little bit better. So we could use telehealth to do assessments, to provide consultations to providers in counties that don't have access to specialty care, or even to do some treatment. And we've actually done some of all of those things. And so that's a concept that works really well in mental health care because for the most part, we don't need a stethoscope. We don't have to touch the patients we work with. A good televideo connection like what we have right now actually works great to meet somebody, to do a good assessment, to even do some treatment, and maybe to pull in their local provider in a three-way conversation where we're saying, what do we have here? What is it that between all of us we could do to make a difference? So this is something that has a lot of potential. We have research to prove that when you do that well, it can be very, very effective, both for assessment and for treatment. And it's sure a heck of a lot better than getting on a long wait list, 3 or 4 months wait list, and then driving to Seattle, having a one-time encounter with a specialist here in Seattle, and then going back to your community without much input to your provider. So telehealth, telepsychiatry is something that has a tremendous amount of potential. We're very interested in it, but we do have still some significant barriers. So I'll call out a few of them. So I have a psychiatrist who is 4 offices down the hall from me here, who is currently working in a federally funded project where he's providing telepsychiatry care to 5 rural primary care clinics in Washington state for patients who have bipolar disorder or post-traumatic stress disorder. So these are people who have pretty significant mental health problems. To get him be able to do that, we had to get him credentialed in as a provider in every one of these 5 clinics. We had to get him electronic health record access to 5 totally different electronic health record systems in these 5 clinics so that he can read the notes from the provider there and he can write notes into the electronic health record there. And there are significant cost implications to doing that, and it's just a lot of work. We had to get him paneled on the provider panels from all of the insurers that these clinics are seeing patients from, which was a lot of work. And then I'll get to payment. And then, this is funded right now from a research study, but the clinics are liking what we're doing for them, and they're saying to us, when this study is over, how do we continue to do this? How do we continue to bring you out here into our clinics so you can treat our patients here? And there, we have all the barriers we just mentioned before, but we also have a significant payment barrier. So especially for patients who are on Medicaid or Medicare, the fee-for-service reimbursement rates for psychiatry or psychology are so low that in this state, about 50% of psychiatrists who are licensed to practice in the state don't take Medicare or Medicaid. They basically say, we'll work with commercial payers that have slightly better payment rates, or we're just going to go with a cash-only practice. And that's not something I'm very happy about, but it's a reality. And it has to do with, the existing payment rates that we have on a fee-for-service basis. So for us to have somebody to say, I'm going to do telehealth consultations and treatments in a rural county somewhere, if it was paid any less than what we can get paid in our clinic here, it would be a complete non-starter. We couldn't find anybody, frankly, to provide that kind of service. In fact, the true costs of doing this is actually slightly higher for us to do it, to a rural setting than, if it's somebody who comes to one of our clinics, because we have the same time costs, the same physician costs. We have costs on our end, related to setting it up, and there's costs on the receiving end to making sure it works well. There's also a little extra time often that we need to have good communication with the provider at the distal site. So, I'm trying to make a plea for the fact that, or the reality that, while this has a tremendous amount of potential, and we train all of our psychiatry residents who come here to the university now, they get a substantial amount of training, not only in integrated care and in working with primary care providers, but they are actually getting training in how to use telehealth and other technologies to do that kind of care. But in the long run, outside of special funding or grant funding, if we don't have payment rates for the service that are at least as competitive as what we might have if somebody comes into a clinic visit here, I would say we would have very little chance that all those really well-intended providers that we're training are going to be doing a lot of telepsychiatry care. So I'll stop here. It went on for a long time. I appreciate John, for letting me bring this issue.
Thank you, Jürgen. Maybe we can open it up for questions and start with Senator Becker.
Thank you. Hi, Dr. Unitzer. So I have a question when it comes to telemedicine psychiatry visits. Are there facility fees included in the way you charge out for those services, or are they just straight the professional component of it?
It's all professional fee billing, the way we do it here. So we would charge, Medicare or Medicaid, the same professional fee that we would charge if we were doing it in one of our primary care clinics here.
Okay, thank you.
Representative Ruccelli has a question. Go ahead.
So I just wanted to ask you to clarify. So are you saying even if they're, like if we pass something like they did in Idaho with parity with for Medicaid, that's still what is way below what would do? And then my other question is just, do we have, you talked about the physician shortages in rural areas. The concern I have is just, is there capacity even in our urban areas? So telehealth, we talk about, we talk about access and creating access, but if we're, looking back to shifting where folks are going, obviously that we get to questions about how we get more providers, et cetera. But right now, I guess I'm just wondering, getting a sense, if we are able to do more in telehealth, are we actually even denting the access problem? Is there that capacity right now?
Yeah, no, this is a great question. They're both great questions. The first one, yes, I think if we had, fee-for-service payment rates for evaluation or E&M for psychiatrists or psychologists to provide services into a clinic, they would have to be at least, competitive with what you would get if you provided that service in a clinic here, if we wanted providers to be able to offer that kind of work. The second question is a really good one. And so do we have enough providers anywhere? So what I think, if we take, in the state of Washington, if you're living with a serious mental health or substance use problem, the chance that you get to see a psychiatrist in the next 12 months for this mental health or substance abuse problem are about 10%. If you're in Seattle, it's probably 20%. If you're in a much more rural area, then it's much, much lower than that. The chance that you see a psychiatrist, a psychologist, or any kind of healthcare professional that has training for a mental health or substance abuse problems is about 20 or 30%. So 1 out of 5. So we have a tremendous amount of workforce shortage. And if you just take office-based mental health psychiatry outpatient visits and you distribute them using telehealth, we're not going to get more visits, right? We're just going to take a few visits that I might do in an urban setting here and put them out in a rural setting. So I think that's a very, very good point. It makes more equitable distribution, but it doesn't create, more people served from a state perspective. I think there are some upsides, though, for doing that more equitable distribution, because in our experience, when we consult into primary care clinics in a more rural area, the providers get a tremendous amount of learning from that. It's not just that one client, that one patient that you help them with. We have a program that we've run now in a good number of primary care clinics around the state, where we have a psychiatrist who consults once a week on a scheduled basis on a caseload of patients into primary care clinics. And it's not just the patients that we consult with that we're helping. These providers are learning a ton when we do this work with them, and they're using those skills that they're learning as part of this consultations on a lot of their other patients. So I do think it leverages us a little bit better if we redistribute using telehealth. The other point, though, is when you're using telehealth technology, you can do things other than just seeing one patient the way you would do in clinic. So a lot of what we do is in our mental health integration program that we operate statewide, I would have a psychiatrist who might spend 2 or 3 hours on televideo with a staff member in a primary care clinic, and they would review an entire caseload of patients who are seen in that clinic, where a primary care provider might have started treatment. And we might review 5, 10, 15 patients and give recommendations. We wouldn't see all those patients, but we might say there are 1 or 2 patients here who are so complex that I'd like to see them. And then we would do a full-on telehealth visit for them. That is work that is billed in a different way. There are now a set of new billing codes called collaborative care billing codes, where the primary care clinic can charge for providing that kind of care, which involves psychiatric consultation, but not face-to-face psychiatric care. That's a nice way to try to leverage a psychiatrist a little bit more than just redistributing a limited number of office visits.
Can I just add one thing?
Yeah, go ahead.
Yeah, and I think the other thing too with the redistribution is also, what I've found in my day job is if somebody's meeting with a counselor, then now they have access to a dietitian via telehealth because they're familiar with the mode of delivery, and so we're creating greater access that way too, in something that we might have more opportunities to serve people. So that's what I thought. But yeah, thank you for your answers. It seems like a massive puzzle, and everything we talk about ends up eventually going back to how we need more providers.
Yeah, and
yeah.
I think we will need more providers, and I will take every dollar anybody will give me to get more people, to train more people, and not just psychiatrists and psychologists, but train medical assistants, primary care providers, nurse practitioners in the skills needed to take care of somebody with a behavioral health problem. But we also are training, I think, providers to work a little bit differently. And I think technology really does help you, not just, if you do it right, not just, redistribute, but also maybe leverage and have a little bit more effect. I want to just call out and thank the state and Senator Becker in particular for really a couple of years ago saying, we're never going to have enough psychiatrists. Can we give some support to having you guys train other healthcare providers around the state? And we've done that using ECHO. We've done that using, telehealth. We've done that by training psychiatrists in how to do this work, because most psychiatrists come out, they're used to office-based practice. They're not comfortable with working with a whole caseload of patients that's really being treated in a primary care clinic. So we actually have put, every year we're now putting 15, 20, 30 psychiatrists through training to have the skill. And it's more than what you guys talked about in the beginning. It's more than just knowing, how to turn on Zoom and what the legal requirements are. It's really, to do this well, we spend a whole year with our psychiatry residents teaching them how to really be effective working in a telehealth kind of way.
Very helpful. Other questions or comments for Dr. Innitzer?
Hi, this is Sarah Orr with Seattle Children's. I was wondering if you found that your professional fee reimbursement rates are lower, the actual amount that you're getting back is lower for in-person versus telemedicine, and then what that delta is.
It's not lower for in-person as far as I know, although I tell you, we do a very little fee-for-service billing at this point for telehealth. Most of the work we're doing is supported either by federal grants or through contractual relationships with managed Medicaid providers in the state.
Mm-hmm.
I don't think that the fee-for-service reimbursement currently would be attractive enough to get a lot of our, say we graduate a resident, for that person to go out and say, I'm going to do 50% of my practice selling psychiatry services fee-for-service. I think we don't have fee-for-service revenue that would really make that possible for people at this point.
Thank you.
Any other questions? Okay, well, great. Dr. Nutzer, thank you for joining. I know you need to run in a couple minutes, so I really appreciate you joining. So next, I want to turn it over to Senator Becker, and she was going to walk us through the timeline. So just for everyone to make sure you understand, we need to have a document to the legislature by the 1st of December that really outlines the nuts and bolts of a pilot program. So what I'm going to do is I'm going to share the language from 6399, and I'll turn it over to you, Senator Becker, to talk us through that timeline.
Okay, well, I actually went to staff to make sure that I had everything covered in this, but it depends on when we want to, what we call drop a bill. And something to do with telemedicine, I think, is most important to have dropped early. You have a better chance of having a bill heard if it's dropped early. Do you agree? And so if we were to pre-file that bill, that means that we could drop the bill the first week of December. And if we drop the bill the first week of December, then it's out there, it's public, people can see it, and chairs can say, I want to hear this, I don't want to hear it, or contact the sponsor and say, these are issues, and start working it at that point in time. So I'm going to go from working it backwards, and I'll just start at the bottom of my sheet. I talked to staff about the timelines around how long would it take if we write a new bill, or if we simply tweak the bill from last year, and it would have to be minor tweaks, would only take a week or two. But I think what we're talking about here is more than minor tweaks, and I would suggest probably that we just write a new bill and bring it forward. And if that's the case, then we would have to have concept language to the staff members to start writing this by around October 8th to the 15th. That would allow them then about a 3 to 4 week period to actually provide us with a first draft of a bill. At that point in time, I would suggest that what we do that would give us till about November 12th to have that first draft ready for us to review. And then we should, by the 13th, distribute that to all of the coalition members so that the membership could look at that draft and have suggestions, edits, etc. I would suggest that they go to you, Dr. Scott, to distribute out to them and then have them bring it back to you so that that could be tweaked at that point in time. By November 22nd, we need to be sending that to the staff. And I'm talking to whether it's done in the House or in the Senate, to our legislative staff. And then that's when we would get the final draft from all the agreed to from the code, or final bill from the code revisor's office. And then then it's the sponsor's obligation to gather signatures, or even just email solicit it, as long as it goes in that first week in December. Okay. So that is a short time frame. These dates are not set in stone. These are just, we're looking at what may happen. I mean, that's during Thanksgiving. It's time where people take vacations. And we just need to make sure, and I'd like to say this, when we send something out for that first write, is that conceptually and we have pretty much an agreement. If we get into the second draft, we should be looking at tweaking the language, not the policy. If we get into that discussion, it'll slow it down. And so I think that once we have those agreed upon concepts and that general language, they'll get this done as quickly as they can.
That's really helpful. It sounds like what I'm hearing is we really need to start with policy, and that probably needs to be done in the next 6 weeks.
Correct.
Okay. Good. Questions for Senator Becker on the timeline and the process? Okay.
I love it.
Great. Okay, so what I want to do for the next hour then, or next at least 45, 50 minutes, so we can leave some time for public comment, is to now start to roll up our sleeves and start talking about the parity pilot. And I pulled up 6399 that we need to come up with recommendations how this would be structured. And there are 4 conditions in particular that we would be addressing: diabetes, stroke, psychology, and psychiatry, I think, was the intent there, and then opioid use disorder.
Hey, John, this is Jürgen.
Yeah.
Just one more comment. So psychology is a little specific, so you might want to broaden that a little bit. Thank you.
Okay, thanks, Jürgen.
So diabetes is a disease. Psychology is not a disease.
So what would you suggest then, Dr. Unitzer, for instead of it being psychiatry?
Mental health.
Yeah, diagnose mental disorders or something, because diabetes, stroke, opioid use disorders, those are health problems, right? And psychology is one type of provider who can help you with that. So just to be consistent, what I might say is, diabetes, mental health and substance use problems, that's broad, but if you want to go more specific, you could say diagnose mental health disorders, stroke, and opioid use disorders if you want to be focused on that. But just to be consistent, I would go with, mental disorders or mental health problems or something like that rather than psychology. Sorry, that's just a minor thing, but that would make it more consistent.
Yeah, thanks, Jürgen.
I think you need to have a chemical substance rather than specifically opioid.
Did everyone hear that? Dr. Schmick was saying, Senator Schmick was saying, rather than opioid use disorders, like the chemical dependency or substance use disorder. Okay. So
you could say mental health and substance use disorders. You could put that as one category if you want to go that broad.
Yeah.
And we could eliminate the wording for opioid and just do the 3 in the study versus.
Yeah, that's going to be more inclusive. It will obviously have a large component for the opioid use issues. Okay, so what I want to do now is maybe turn it over to Chris and Brody, because you guys had sort of really started to get into the weeds last time, get down to the details, and I wonder if we can kind of pick up our discussion last time. And just to cue you a little bit, we talked about RVUs and how RVUs are so relative value units, and they are broken out into different components. And we talked about the importance of definitions. So I'm wondering if I could cue either Brody or Chris to start to elaborate a little bit more and how that then gets written into a policy. Did we lose Chris? And
yeah, I'm here. I believe there was a meeting in the last couple of weeks. I was out on town on vacation, so I am not as caught up. So I don't know if
you know what, Chris, you didn't miss anything. Yeah, Chris, you didn't miss anything because we only had 3 people who could make it, and so we just canceled that.
Oh, okay.
And Cheryl's on the line as well.
Hi, yep, this is Cheryl. I joined a little bit late. Sorry about that.
Great, thanks, Cheryl.
So just, I guess I could recap a couple of things we discussed. I'm not sure where we go from the recap. Is there just a couple of issues? But one of the things that we kind of discussed was that this is my understanding of the way that Medicare works, is that the RVU associated with the CPT code that is billed, when it is billed with place of service 02, which is the telehealth place of service, that it utilizes the facility RVU, which is generally speaking a little bit lower than the non-facility RVU. And as we indicated and heard earlier today, that in the cases of telehealth, there is no facility bill that is charged alongside with that. It's all professional. So even when we talk about parity, like I guess following Medicare, there may be a difference in payment just as it uses the facility RVU instead of the non-facility RVU. So that was kind of one point that was shared. The other piece that was discussed was related to the intended, if this is meant to be a study and we're supposed to learn something, to have really clear metrics as well as an understanding of like when we feel like we've learned something. Because if the goal was to determine that that the cost will not go up as a result of reimbursement parity, like how do we know we've accomplished that? And so there's just this category that we covered about related to, you know, exactly what are we looking at and how do we know we've accomplished what we intended on learning. That was another category as well. I mean, and then I think the third category has a lot to do with just the delta of what all of our reimbursement policies today, how it compares to this reimbursement parity. And I think that each plan has their own nuances and differences to that. But I think one of the, I could just say from the region's perspective, the delta that we are seeing here is that while we use the same conversion factor for reimbursement, so we aren't lowering the conversion factor that's multiplied by the RVUs. Generally speaking, for evaluation management codes, our coding specialists and policy folks have identified, they try to find the most appropriate CPT code for that. And there is a list of CPT codes that they determined had a clear tie to the definition of what an E&M code was, which does result in a different RVU, but the conversion factor is the same. And so those codes are like 99441 through 99444 for E&M services for physicians. And so just pointing out what our delta is, I believe that Melina doesn't have that same delta. I don't want to speak on behalf of Chris and Cheryl as to whether that's a delta for them, but I guess the third category of topic to cover is just understanding where the delta is between our reimbursement policies and this proposed study. So that's kind of, I think, the 3-point summary that that kind of highlights some of the major things within that document that we sent out. So I don't know if Cheryl and Chris have any additional thoughts to add.
Yep. Brody, before we turn over to Chris and Cheryl, we had a question here in the room.
So this is Senator Becker, Chris. So from my years ago of doing coding, it seems to me that the 99441 through 444 are actually hospital E&M codes and not the office E&M codes, because you have the 99211 through 99214 and then 99201 to 99214 for office codes. So these are, if I remember correctly, hospital codes. They're outpatient codes. So outpatient. Oh, you're using consult codes.
99441 or 99241? I've got the codes pulled up.
So this is
441 through 444. So the definition of 441 through 444 is phone E&M physician or qualified healthcare professional, 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes. So it's specifying the modality, while the 444 is an online, so that's the one that is being used for video.
Yeah, so Primera is slightly different in that we don't require the use of the 99441 through the 444. You can use the E&M code and modify it, put a modifier on and the place of service to show that it's a telehealth service. Or use the 99441 through 444. Either is appropriate.
Yeah, I remember Francis from Molina saying the same thing.
Yeah.
I'm not to get, sorry guys, right? For those who are not billers, this is pretty different, but there's a 9944 code, which is specifically kind of set aside for kind of like telemedicine, and these other ones are either outpatient consults or inpatients. And I think what, Brody, the big difference is, I think I'm kind of hearing a consensus that to get parity, you would need to have the same code as if you were seeing them in person. So there's, you know, a
delta
thought that you don't even use the 9944 codes, right?
Well, and in truth, a consultation has certain different requirements with it versus a 99202, an office visit. And so you're actually downcoding, from my perspective, using a 99441 through 444 for what you should be able to charge you know, an office E&M code.
For group or for labor and industry, that is the way that we do it. You would use that that E&M code and then put the modifier.
So use the
which E&M code? Consultation code?
No, not the consultation code. The 99214. Or,
okay, good.
Or the office. Yeah, the office.
Okay.
It's the same exact type of code, that whether or not you were seeing face to face or not, with the modifier, and then you have to substantiate that that you actually did that through telemedicine in the notes.
I see. So there's really people are doing three things. Some people using the outpatient code, some people using the consult code, and some using the 9944 telemedicine code. Is that right? Is that a good summary of what's going on? Okay. So as a group, can we kind of come to a consensus as to which one we should use? Or can we at least rule out one of those to maybe simplify them?
If you're driving towards parity, that is why I would assume, I wasn't there when they made this policy, but I would assume that's why they made the policy, so that whether you're doing it face-to-face or you're doing telemedicine, there is parity, except for the facility.
So a question I have of L&I then, if you're using the E&M office codes and you have a modifier of whatever your modifier is, are you then reimbursing less for that telemedicine? So you're reimbursing at the same consistent rate.
Now, there are additional pre-authorization requirements with referral from the attending physician. There's some additional steps that are maybe some administrative burden that they've put in the policy in order to get there. But the billing itself and the payment are exactly the same.
I don't want to go through prior authorizations and referrals for some of these people that may be out in the country, that referral and authorization is going to take a week, 3 days to a week.
That's our current policy, because we've been accepting telemedicine from an originating site. A medical site, not home, is one of our barriers to what you're actually have drafted in 6399. But we've been accepting and allowing payment for these services for a number of years. So, but that is the way it currently is. There is a step.
Comment.
There's a comment in the room here.
I was just going to interject. Payment parity is, I'm doing the same service, I'm using the same skill set, same time. Therefore, we would advocate using the same code. And just to kind of put a cap on that, I use my online tool to look up the code, and the reimbursement for 99442, which is a phone, is like $27, where in 99213 is $74. So if we were to anyway advocate those codes, we'd be shooting ourselves in the foot as far as parity.
So I just want to make sure everyone heard the comment is that the difference in getting down to dollars between a 9944 code is about 27 versus what John Bose was proposing was about 73. So it's a real big difference in using that 9944 code. Brody, not to beat up on you, but I think that there's maybe using that 9944 code is not I don't think too many people would perceive that as being parity.
John, this is Chris. If I can add a couple bits as well. So I think one, I think when we think about telehealth, my suspicion is we're commonly thinking about video visits, but there are other kinds, right? There are e-visits, there's e-consults. And so I think those may require different types of billing. I think they're not all the same in my mind, at least. So at least within KP, for example, we are taking video visit coding as the E&M code with a 95 modifier. But for e-visits or e-consults, we're using the 99444. And in fact, for e-consults, we're looking at broadening those to a 446 to 49 range because they're different. They're store and forward. They're not real time. They're useful and they are telehealth and they are real care, but they're not the same as a real time interaction. So I think it matters with which type of visit we're talking about, and we'll probably need that specificity.
I really appreciate that, and you would not get any kind of disagreement from me about that.
So Chris, just a quick question, because you said on the consultations you're kind of using it, store it forward, et cetera. But if a physician actually meets all the criteria for an office call of, say, a 99213, you wouldn't downcode it from his office call if he put the modifier for a telemedicine visit, would you? What are your documentation requirements?
So I'm not the expert, so I'm a little bit guessing, but I think that for telehealth encounters right now, we are only accepting the E&M codes with the 95 modifier or the 99444 for store and forwards. If someone submitted a different code, I suspect our billing department would send that back and ask for clarification.
Okay.
I'm not entirely sure, though. I'm just guessing. But I'm looking right now at the codes that we expect, and I don't see that on the list. So I think it would result in an error, if you will.
Thank you.
Chris, does the 95 adjust the reimbursement, or is it the same as a 00 modifier?
Currently, it's the same. Now, granted, we have a very, very, very small use of video visits outside of our internal practice, so the volume is very tiny, but the reimbursement is the same. I think, honestly, partially because it's such a small volume that it hasn't really been addressed.
And then, so for Primera, it would be adjusted based on what the RVU is. The conversion factor is the same, but there's a small adjustment because of the difference in RVU.
Is that related to the facility, non-facility?
Yes. Yep.
Aspect of it?
Yes.
Yeah.
Cheryl, what code would you recommend for a Skype-like visit with, say, Dr. Unitzer beaming in to Colville and seeing a patient? What would you recommend for that? Because that's what we were talking about, is this face-to-face video visit.
Well,
I don't know
what code is being used now. I think it would be the same.
Well, I'm asking you from Primera, how would you want that to be built?
Well, so they could either use the same code and modify it,
okay,
or it could go to the 99441 series codes.
Okay, all right.
It could be either.
Yeah, I'm wondering if we can come to a little bit more of a consensus on these codes. Can we maybe for this discussion take the 9944s off the table, because it's really not parity when it comes down to the dollars. I think we're going to be very, very far from parity for this.
Were those not drafted with the intent of forward being specifically store and forward to differentiate between store and forward and a video live feed?
It says the specific language from CMS is telephone E&M service provided by a physician.
And there's actually draft language from CMS that's out there to cover the e-consults that Chris was talking about. It just came out this summer. So there's a little bit more.
The 446 to 449.
Yep.
I'm reading right now. They're defined as doctor-to-doctor telephone / internet consult, which to me sounds like store and forward, an e-consult.
Yeah, I would suggest that store and forward use the 9944 codes. Yeah. And then we use either the consult or the outpatient visit codes as for this pilot.
As legislators, this is really important, because of whatever we determine here, and this is what we're going to do. because of the payment differential, we're going to have to consider doing this for our Medicaid population if we really want the service to get out there. So it's important we have an idea what the dollar amount is as we move forward, because it's up to us to make sure the service gets out in that population. And so that's why it's kind of important.
But I think it's important that we've got a pilot of Dr. Unitzer's in Eatonville, and my superintendent of that school said this is the most amazing thing we've ever had happen here, but it's only for Medicaid.
Yeah.
And we've got to remember that mental health or illnesses don't care if you're on Medicaid or if you're on, the best insurance in the world.
But that's why there has to be the parity, though, between the payment reimbursement, or else you're not going to get providers.
Are you suggesting that we can alter the Medicaid reimbursement rate? Because I don't think we can do that. That's under managed care.
I think overall, I'm looking at the policy, looking ahead. If we're going to get this service out to the people and we have a shortage of providers, if there's any discrepancy between Medicaid and what private pay is, you're not going to get utilization, in my opinion, or the providers aren't going to be willing to do that.
Well, I'm confused. We could bump, give a bump at the state. Yeah.
Well, yeah.
Yeah.
But this is what we're talking about.
My other question was just because it's on my second meeting on the consults. Folks aren't trying to push for parity for e-consults.
Not e-consults, no.
Because I could see a whole bunch of.
No, I don't think anyone's saying that, Representative Riccelli. Yeah, I totally agree with what Dr. Cable said, that they're very different. They're quicker. You're obviously not examining them in any kind of way. So I would say that e-consults should be under the 9944 codes, which are lower.
Although, John, just briefly, I think it's one of the points Brody was raising is that when you say parity, do you mean RVU reimbursement rate parity, in which case, once you've used the proper code, parity naturally follows, and then the decision becomes which code do you use. So in that light, I guess I would feel like using those 4.4 codes, e-consults are parity, so to speak, because you're using the right level of code for the right level of value, and the RVUs would not be any different. Reimbursement would match the RVU value, if you will.
Well, we all have RVUs and conversion factors, but the clinics are going to negotiate those rates with you, and we would not do anything to affect their ability to negotiate the rate, correct?
I guess that's the question in my mind is when we say parity, for example, could KP, if we see a 95 modifier, say that's fine, we're going to acknowledge the 2 point whatever RVUs, but the conversion rate's different because it's virtual. So I think the conversion rate question is one of the embedded in the parity discussion. Is the conversion rate the same we use universally, or could an entity craft its own conversion rate for telehealth encounters, which would apply to both real time and store and forward?
Yeah, Chris, can you say a little bit more about that conversion rate? I have to admit ignorance on this, and what does that mean?
The dollars paid per RVU. So we have a variety of contracts, a variety of groups, and for every group we have our own unique payment rate for the RVUs. But for all of the care within that group, the rate is the same. The conversion factor is the same.
Okay.
Well, I would think on negotiated contracts, it's whatever you negotiate. I think what we're talking about is what the state reimbursement is, right?
Yeah. I got to say, within a given contract, can you have a differential reimbursement for telehealth? And if you do that, have you violated a concept of parity?
So this is Cheryl. My thought would be that the RVU differential would still remain in place as long as the conversion factor is the same. Then you've got parity.
Yeah, I would agree. I really think that these things parity needs to be measured in RVUs, because everyone's going to have different conversion rates that they're negotiated. We should not be in the business of saying everyone's going to get the same dollar amount. But RVUs, I think we should. Does anyone disagree with that?
Well,
RVUs are not, I can't remember, who sets the RVU? I can't remember. Isn't that
CMS?
Is that CMS? Yeah. I was afraid to say that, but for fear of not remembering correctly. So the RVUs are already a set standard. It's the provider or the clinic's ability to negotiate those rates.
The conversion factor that's applied
Right.
to the
But my question then goes back to, if you use the 95 modifier, you're saying that the conversion factor is different from, say, a 99212 without a modifier of 59. And I'm saying, I'm thinking when you're saying the conversion factor is different, that it's less for a telemedicine visit. Is that correct?
For Premera, it's the RVU. We use if the conversion factor is the same, but the RVU has variability based on Medicare setting that RVU differently.
So let me expand on that. So 99213, right, which is the code of interest that everyone has, 99213. Medicare has set an RVU for a non-facility setting at 2.06. Medicare has set an RVU at the facility setting for that same CPT code that Medicare has set the RVU at 1.44. So there's a difference there. And according to Medicare, when someone bills with a place of service 02, the RVU that is used is the facility RVU. And so the conversion factor is the same, the CPT code is the same. Because of the place of service, Medicare uses the facility RVU in that case, and there is a difference from 2.06 to 1.44. That is what Cheryl is trying to describe.
Okay, that makes sense. And I mean, I guess you could explain that because that movable RVU is a sum of both the pro and the facility, we should subtract out the facility portion of that. I mean, that makes sense.
Yep. Right, and that's why Senator Becker was asking if a corresponding facility charge comes along with that, and our understanding is that that there shouldn't be one.
Yeah. Can we point out, this is Adam Rowney, can we point out though that Medicare does also reimburse an originating site fee? So there's not a facility fee, but there is the G code, the originating site fee that Medicare does pay.
Yeah,
Sure. The originating site is at if that's like at a hospital or something like that, but if someone's at home, we're not going to pay a facility fee to the person's home, are we?
Right.
Yeah, and Adam, it's like Q3014, I think, is the code, and it's usually like $25. It's not much.
The maximum fee is $36.70.
36, yeah.
Yeah, I just want to make the point that we shouldn't say there isn't ever any reimbursement for some facility involvement in the service because of that G code.
That's correct. That's correct.
But there is a difference
to the home setting
with the provider that's actually providing the medical advice, because they're not getting that Q3014. It's the facility where the
remote site.
Yeah,
so let me play this out in my simple brain. So multi-care in Eatonville has a patient present that needs immediate help, okay, whatever it is. They, in that clinic then say, you can either go home and make this call, do this, or you can do this here. But if they have that patient in their clinic, they should get an originating site.
They will get $36 dollars for being the site where it's actually happening.
And that's the way the first bill was written, so, okay, good.
So let me get some reactions from providers. Sarah, Chad, Kathleen, how do you guys feel about a pro fee only and taking out this facility portion of it?
So this is Chad. I guess just to clarify, and forgive me because somebody grabbed my attention. Are you suggesting then that, like, if we are working with a partner facility, that they actually not charge the facility fee, and that we as so the originating site wouldn't charge a facility fee, and then we as the provider would only charge our pro fees? Is that kind of what you're indicating?
Let me make sure. This is what I think would happen in that if you're working with an outside entity, Chad, it's you, Virginia Mason, no facility fee, only pro fee, and then that remote site gets the Q3014, the $36.
Okay. Okay.
And remember, it's only for those 3 identified areas in this pilot.
Right.
This is Kathleen. We don't charge a facility fee for the provider side. We just charge a pro fee. I don't think that would be an issue for our organization. This is Swedish. I don't see that that would be an issue because the pro fee is the major portion.
Yeah.
This is Sarah. That is current state at Seattle Children's also, and as has been discussed, we can't charge a facility fee when we're doing these services when a patient's located anywhere other than a designated healthcare facility, which is a huge problem for us in our telehealth program because our providers are here on site doing the service anyways, but the patient is, you know, out of school or at their home. So we're still using all of our facility and operations and infrastructure and hardware and everything to do the appointment, yet we're losing out on that because the patient's at their home instead of at a different site. But that issue doesn't change regardless of it's for this pilot or in current state today.
Yeah, I totally appreciate that, Sarah, and I'm in the same shoes. I think I just want to see, for the purposes of the pilot, where we're only talking about 3 conditions, do you think that have enough of a, you know, boundaries around it where it wouldn't be such a huge hit financially, and that we could do this?
So if I can add to that, you're looking at 3 conditions, but you're also looking at only certain CPT codes. You're not looking at all of the CPT codes.
Right.
So it's a limited study.
Yeah. And I'm personally okay with it because I think there's enough guardrails around it, and we still do a lot of contract business.
I'm struggling to see how Seattle Children's would participate in this study, given our patient population is obviously pediatrics. Some of these are outside of our realm.
No, there's mental health and there's diabetes.
Mm-hmm. Sure, many of our services like that today are contract services like we were talking about. We're getting reimbursed the same pro fee as we are telemed versus in person. So I don't see the problem why we would need to participate in the pilot.
Okay. You're already getting parity is what you're telling me.
For video, yes, but I do like the piece in this legislation about store and forward and opening up the door to other types of things like e-consults and such, because that's where we would find the value.
Great. Maybe we'll parking lot e-consult and store and forward for now. Let's just try to talk about live video.
Can I ask about Representative Schmick's question though? He was touching around basically the incentive, why folks would do this in the Medicaid realm and talking about some sort of bump. And I do think it's worth considering, like, what would the cost be? You probably don't want to weigh a bill down, but it would, you know, if there was some sort of Medicaid
So right
bump.
now with your Medicaid, you're all on managed care.
Mm-hmm.
And as Dr. Unitzer pointed out, you're not being paid fee for service. You're being paid a per member per month.
Right.
So that probably is, you know, depending upon how much that managed care organization takes down to that provider, that's where you would have to address that issue to see how it's contracted.
But I guess it's interesting for that price, we allow that through negotiations where other states have said this is the Medicaid rate, right? Am I wrong? But we're moving to value-based payment, but
they're at the per member per month rate right now with Medicaid managed care. That's the difference. And they're probably doing better than the fee-for-service rate.
Right.
So I'm not sure that
take counterpoint.
Okay.
But listening to Dr. Unitzer speak of this, currently, you're 1 in 10 seeing a psychotic psychiatrist, and 20% seeing another mental health professional. He has repeatedly said, because it's not the only time I've heard him say this, that those lower rates, and I guess, well, they need to find out what the managed care is paying those.
No, you got it back. He said the fee-for-service rates were not, the fee-for-service rates are not acceptable. They're doing okay.
The MCO rates then that we are currently paying our folks for Medicaid population, is it a barrier to where they don't want to treat? Well, because there's a lot of counties we don't have, because what I'm getting at is that every time we underpay Medicaid,
oh, I totally agree. I mean, I was in that business.
to the private, and yet but we're talking about individual markets, the small group markets, which are totally not very stable in our state. And so I want us to consider that because I think it's a cost shift to those other markets.
So Joe, I think what we should do before we even consider that is reaching out to Sue Birch.
I agree.
And asking her about what that rate is, because I had a conversation with her last week, and she's concerned that most of that payment, or too much of that payment, may be going to administration versus passing on down to the providers. And if you are looking at contracted providers, i.e. the one out, say in Eatonville is contracting with an MCO, are they getting paid the expected rate, or that's what we need to look at?
And we have a test case though, right? We just bumped for children Medicaid reimbursement rates. We did that. I mean, we could see how with that incentive. I mean, we can look at.
And we can look at.
Welcome to our world.
But I think that's a separate.
Okay.
We shouldn't.
Well, but I do. In terms of this, I would agree. But I think overall, looking system-wide, we've got to consider that.
I would love to see rates bumped up for Medicaid.
So, in terms of a follow-up item on this, Senator Becker, would you mind reaching out to Sue Birch and exploring this issue? And Cara, can I ask you just to maybe follow up with Bergen about, just to clarify whether we're talking about the commercial rate not being as high, or is it the Medicaid MCO not being high? I just want a little bit more specificity around that. Could you do that for me, Cara?
Yeah, you bet.
Great, thanks.
John, this is Frances Goff. Could I just say a couple things specific to Medicaid from Melina's perspective? Thank you. So, Senator Becker, I really wholly appreciate you reaching out to Sue Birch and seeing what might be done. Historically, Medicaid rates can't compete, certainly with the commercial markets. And I can tell you from our experience with integrated managed care in the couple of the ACH regions that we were fortunate and honored enough to win for the past couple of years, that we have had to do a lot of work with local providers in terms of trying to be able to, and not just local providers, but even, third parties that we're bringing in that are more national telemedicine providers for behavioral health, for example, because the rates are traditionally so low, and they're low for the, in-person environment, the clinics, and certainly that translates over into telehealth. And so what we've tried to do is try to work in a pilot perspective to try to say, well, we're learning as well as to how we can best facilitate and provide these services. So what are the costs? What is sustainable? What does it take to be able to provide these services and pay providers appropriately to be able to deliver these services into these rural communities? And, we are paying higher rates in the rural areas than we are in urban areas for in-person services. And we are doing the same on the telehealth side to be able to provide the services at all. So it's not a sustainable model based on these rates, because we're not budgeted sufficiently, and we can't maintain the PMPM required necessarily to be able to pay on a widespread basis. But we're learning a lot as we're going. The other thing is, and someone mentioned this before, under value-based purchasing or value-based care, we have now about 59% of our Medicaid membership under value-based care contracts. And so in that environment, it does make it easier because now we're partners to do be a better job with looking at this more closely and building those in as potentially part of our downstream contracts. I think in general, telehealth has a lot of, in the Medicare market, Medicare environment, and for a managed care organization, using that as a vehicle, I think has a lot of utility when it comes to telehealth, and certainly should be part of those contracts in the future. We haven't really looked at those specifically yet, but that would be the next thing as we figure some of these rates out. But it's a big challenge, so appreciate whatever can be done at the state level.
Much appreciated.
Thank you, Frances. Glad you joined us. I'm wondering if I can get a little bit more feedback from my provider colleagues like Kathleen, Josh, even Cara, and give you a chance to say more of the last comment. So, and this is really what we're reacting to is what Brady was saying, that we take away the facility fee. We're using Medicare RVU targets for each of these CPT codes.
And the one thing that I'm hearing that I did want to comment on is it sounds like since the origination facilities, when you're doing kind of the hub and spoke model, they can bill separately for their facility fee when they're the origination place in a facility of some sort. It's really the direct-to-consumer people that are being affected, right? The physician that calls from their office directly into the patient's home that's really being affected by this, if you remove that. Is that correct?
That's right. Yeah.
And it seems to me that that's kind of the one that you do want to incentivize and help to some degree, because when you're talking about somebody calling from a hospital into a clinic, they've probably already got the infrastructure in place that one needs. Those are sunk costs for them, I think. I mean, I do know one person that does it, and that is the case for him. We've discussed this. Whereas when you're calling into a patient's home, those are the providers that maybe you want to give a little bit more help because they don't have as much sunk costs already, and maybe they are more prone to complications. And that's really valuable to the patients to actually call into their home.
May I ask a question of that? So individual providers not associated with a hospital system, it's been a while since I billed. Are they able to bill a facility fee in addition to their professional component? I thought as an individual they could not.
It has to be hospital.
There has to be a hospital.
Yeah, like these are for clinics that are, you know, part of in the hospital or somehow attached.
Exactly.
Yeah.
So that individual provider is
they wouldn't have a facility.
It's not
anyway.
affecting them.
Yeah.
They have no chance. So what if they are a group that's owned by the hospital and their offices are on hospital grounds?
Then I think, Josh, they would be, because if you're on hospital grounds, you do get a facility fee in general. Like I know even in Seattle, the Roosevelt Clinic, which is about 6 blocks from the UW, it also qualifies as getting facility fee.
There's very few groups like that, but there are a few. So then maybe my perspective is wouldn't really be, have an effect because those people aren't going to have an option to bill for a facility anyway. I'm just looking at the big picture as to what you're trying to incentivize there.
Yeah. John, did you want to clarify? Okay, John said he was clarified. Kathleen, Joelle, Chad, how do you guys feel about this?
Joelle has something to say.
You know, there's a lot of considerations here, and I guess I'm always very solutions-based and pragmatic in terms of what we need to be thinking about from a provider standpoint. And I think everything that we're talking about is so key here. My concern is how will we roll this out and how will we communicate to providers? Or our results will be flawed, and at the conclusion, we may really not have the information that we were aiming for. I do think that we need more time as a group or a subgroup to work intimately on this. There's so much to say and so many considerations end to end on this continuum of healthcare delivery.
Definitely agree with you. So we're about another 15 minutes. What I'm going to do is basically try to write a little bit of policy and basically trying to paraphrase what Brody was saying. I recognize, Sarah, that you may not want to do this from a children's perspective, but I want to get reactions from that. And then just to give very practical, one of the things that we had wanted to do is see if there's a way to get a subgroup together to meet a little bit more frequently to maybe start hammering this out. It would mean we'd have to meet probably in the next 2 weeks and come back to the group at our next meeting, because we need to talk about the actual ICD-10 codes that we're talking about. We haven't talked about that, and we didn't even touch on Brody's points about metrics. I think to really move this along, we are going to need a subgroup to meet a little bit more frequently.
This is Brody. If I could add one more thing to discuss in those breakout meetings as well, is that generally speaking, the health plans pay the lesser of what is charged versus what the allowable contract is, and many of the clinics on this call do have public-facing telehealth charges of trying to draw in telehealth in like the $25 to $35 range. So if those are the cases, then would we expect, because the charge I don't think can differ depending on who you are billing. So if you have a public charge of $35 for a telehealth visit, like how does that work in this particular case as well? So,
Same question.
Great question. And Brody, fortunately, a lot of those things that are public facing are not, they're not diabetes, they're not substance abuse, they're not mental health. In fact, in our webpage, we specifically say, this is not for, we're not going to give you psychoactive medications, we're not going to give you opioids. And so, I mean, I know what we see. I don't think in the 4,000 visits we've done, there's never been a diabetes question. There's never been a substance abuse. Now and then we get anxiety, and that might be one area that is part of that.
So there may be some overlap, and maybe others go further than what the UW offers. So I think it's just something to consider, and it definitely has scaling issues. If the goal here is reimbursement parity beyond these conditions, we're going to have to cross that bridge at some point anyway, so it's at least worth covering now.
So, Brody, you brought up a question that I had when I was reading the minutes, but it seems to me, and I don't know if something's changed since I left the medical practice, but we had to charge everybody the same, and then by contract we did a write-off. So we charged a Medicaid person the same as we charged a Premier or Regents person. And then when your EOB came in, we had to do the adjustments there and not charge that patient. But my question is, if somebody is driving patients to their telemedicine clinic through lower fees, are they then submitting a bill to the insurance, or are they just getting cash? And if they're getting cash, what happens to that deductible and whatnot? Is the patient actually coming out and getting the shaft in essence?
Yes, my understanding is the same as yours, but I'm not the expert on that as to what should be done, what's being done in reality. I do not know the answer to that.
If I may speak, this is Kathleen. With the Providence outward-facing providers, as we were mentioning earlier, that don't come up with diabetes or psych issues or stroke, those are contracted with insurance companies through Providence. So if you're calling for a $49 visit and you're receiving advice, consultation for a sore throat, that's just a flat fee, but it's contracted ahead with the insurance provider. If you don't have an insurance provider who is covered under that plan, it's a straight $49 fee. So it's a better deal frankly, it's a much less expensive way to get that health care. Again, it is just it's not acute, and if it's something that's out of scope, they refer them on to a facility that's able to take care of them.
A question here.
Yeah, I think
I was just I think Danny brought this up there. Just recently passed some parity language, and I just wonder when we talk about which CPT codes that they're going to have in the pilot and those sorts of things, if maybe we're making it more complicated than it needs to be, because the Kentucky language I'm looking at right now basically says telehealth coverage and reimbursement should be equivalent to the coverage for the same service provided in person, unless the telehealth provider and the health benefit plan contractually agree to a low reimbursement for telehealth services. So they're basically saying, we just want you to cover it the same as you would that in-person service. If it's a new patient visit, you bill a 99203, pay us a 99203 rate. If it's an established visit, you would have billed a 99213, pay us a 99213. So it's less complicated, and it does leave that caveat for those Express Care Virtual or Teladoc who agree to those lower rates. I'm just wondering if that's something to consider, because it just makes it much more straightforward and simple rather than trying to carve out certain people.
And this is Joelle. I totally agree with that. And we also have to consider if this is a true study and our comparator is in-person usual care, and we're not even sure if our patient populations are comparable. But if we start creating special concessions in this study setting, again, we won't really have accurate information, real world information. And we could end up, depending on what our metrics are and who's engaged in this research, and whether or not we standardize and educate. Really, you would need to be standardizing and educating the usual care in-person providers as well. So I think there are a lot of considerations to make sure that we don't really kind of sink the ship before we even get going here by really kind of over controlling versus allowing a natural setting to occur, if that makes sense.
No, I think that was one kind of recommendation, is to really look at the Kentucky language and see if that's just an easier way. But I think we do need to kind of really.
Maybe you could send that to Dr. Scott.
Yeah, I have a copy of it, and I can send that out. Yeah, I will send. Yeah,
I like simplicity.
Yeah. I will do that. I'll send it out to the group.
I would assume there's some paid lobbyists that aren't around this table that would be biting tooth and nail. But I think I agree with you. I think that's the direction we need to move. But I know that I'm jumping into something that you guys.
I don't want to speak for Danny, but I would venture his thought would be honestly to just push for that language versus highlighting, get the language in there and have it be done.
Well, and I think that, kind of comes back to one of my points in here, is that we have to agree on the concept. And if we don't, we're going to have nothing but a battle like we did last year, because we didn't have that time frame to plan and do it right.
Maybe I just want to do one housekeeping thing and then open it up, and that's our next meeting. And I'm wondering if we could possibly meet in Olympia in the next 4 to 6 weeks, if any of you would be willing to host us. I know we've done it before and it worked out, but maybe looking to late September, early October, and maybe we can do that offline, and I'll kind of poll other people to see how we can maximize attendance. But I'm getting head nodding here that sounds like the most likely workout.
26.
26th of September.
Don't set a date yet.
Oh, that would work for me.
All right.
First in.
Well, we're gonna work offline, but for the folks who are on the phone, just tentatively, we're looking for late September, early October in Olympia, and we'll find a time in the next week for that. But I do want to give some time for members of the public to ask a question or make a comment on our discussion. And if you're on phone, please just identify yourself by name and who you're representing. Or if anyone in the room wants to say anything.
Somebody say anything, I got something. Good.
So John, briefly, this is Chris. Just I'm about to enter a parking garage for my next meeting. I suspect I may lose the call. So thank you, and I will be happy to be part of the small group that we convene.
Thank you, Chris.
But maybe off the message of what this group, but I was just wanting to get a sense. I sponsored the medical licensure compact. I know one of my colleagues, Representative Mike Bolts from the 6th District, is looking at the nursing licensure compact with Washington isn't part of it. And I didn't know if this, I was just wanting to take the time to see what people think about that. And
the nursing compact.
Yeah, I mean, I know it's contentious. It's contentious with our nursing unions, et cetera, but I didn't know what folks thought about that.
What's the benefit? What's the pros?
Well, like the medical licensure compact, I think was hugely beneficial in telehealth. You know, we have NPs, right? That with a compact that would work for them, that the same benefits that would have from the medical licensure compact for MDs and BOs.
So would you picture it as RN BSNs, RN?
I don't exactly know what the compact covers. I would assume.
The hang-up has been in the past is all the background checks, the establishment of another database in that, because they've wanted to change, the nurses have wanted to change this for some time. And it's quite a bit more involved, meaning the qualifications across. I mean, I think that anytime we can help licensure between states that's consistent, I'm all for it.
Is it the same language as?
I
know they brought me one a number of years ago.
And that was, I think that's one that one had some issues with, which they talked to them extensively. We'll have to look at it.
Right.
Questions or comments? We had a chat from Katie Cullen at WISMA. I would just like to review the parity proposal, give feedback, and we can do that, Katie. Anything from the TBI perspective?
The TBI community is particularly interested in telehealth, especially in rural communities, that we discussed during the meeting. So it was really interesting for me to hear the barriers and what's going on in the telehealth community and be that to the council. And
great.
So thank you for
great. Any other questions or comments from the public? Marissa or Michelle Martinez, I see on there.
Not at the moment. This is
Drake.
Michelle. Thank you, though.
Okay. Tracy Drake. All right. Well, thanks. I think we're actually ending a minute early, so I appreciate everyone's comments. And we will get those minutes out, and we'll have a subgroup meeting. Hopefully in the next 2 to 3 weeks, we can get down to brass tacks on this. Thanks, everyone.